Thank you, Maria. Dear audience, so I work as the work package leader for this package number 6, screening and early detection for cancer, and we collaborate closely with the coordination of the package together with the YARC, the screening quality assurance group there. And we have 7 associated partners of the project that have been listed. Some of the partners are also responsible of the sub-projects of the work package. So concerning cancer screening programs, there is almost 10 years, since 10 years already, these comprehensive recommendations how screening should be done. So that it is the recommendation of the implementation of screening in evidence-based, organized, population-based manner through a systematic approach and quality assurance at all levels. And you see that there are only 3 tests nowadays for which this recommendation of routine population-based screening programs have been given. So that this evidence-based policy and organized action modality, it includes careful investigation, what is the evidence before deciding of an activity. Also building up the infrastructure for the quality assurance, continuous evaluation and continuous monitoring activities as well. The recommendation includes also careful evaluation research on outcome and potential adverse effects of screening, utilizing screening registers, cancer registers, cause of death registers and other relevant sources in healthcare. And also results of these programs should be, and evaluation research should be properly informed among population at large and healthcare professionals. For example, in case of a potential new cancer screening program, there should be very thorough, long-lasting randomized controlled trials evaluating the potential benefit on the outcome, but also the balance of benefits and harms before deciding on a new program. And then also, in order to maintain an appropriate balance according to recommendations that are also then followed by more detailed quality assurance guidelines for the 3 cancer screening programs at the European level. So it is essential that also to provide proper monitoring and quality assurance throughout the screening process in such phases as informing population, inviting to obtain high coverage, and performance on the screening test and diagnostic workup at large. So even though these recommendations have been given since long, it seems to us that this is not yet fulfilled. The recommendations are not yet completely fulfilled in the European setting. In the most recently published status report on cancer screening that was done already a few years ago, and I think that the next round should be started soon to look to more current information. It is clear that when we think about the context of the overall European Union, it is that just a proportion of the potential target population in the member states have been covered by the population-based full established program. For cervical cancer, maybe 1/5, breast cancer, but 40% of the potential target population were covered at those times. The estimates come from about 2007. Whereas in a very large number of member states, there was either planning or piloting phase of these programs also for the colorectal cancer, or there was no population-based program ongoing at all, meaning that since this observation, many member states have now needed to consider how to start the planning and piloting of the population-based programs. In general, when we think of the screening of these 3 cancer sites, how do they affect on the burden of death from cancer in the EU, so we could estimate that about 1/3 of deaths occur nowadays from those cancers that are targeted by the programs in women, breast, colorectal and cervix uterine together, whereas in many it is about 10%. But when considering potential other programs, maybe future activities or activities in other fields of early diagnosis, it is important to recognize that there are several other cancer sites also that are under evaluation under the RCT phase. For instance, screening for lung cancer as a kind of addition to campaigning or interventions against tobacco smoking, or for instance PSA testing for prostatic cancer, for which cancer site there is already trials showing that there is a mortality benefit also from that activity, about 20% decrease in the death rate, even though the balance between the benefit and potential harm in form of overdiagnosis, overtreatment is extensive, so that when we think in broader terms, not only of the ongoing programs, but also the potential new programs or other activities that we are dealing with these major cancer sites, it seems to me that screening activities affect already almost half of the cancers that lead to death at the European Union. For cervical cancer, this is the only cancer under screening that can very effectively prevent also incidence, about 80%. We could say that there is about half of the potential impact, about the potential benefit of cancer screening has been achieved, so that you see the line about 1 death per 100,000 woman years that could be targeted if the organized population-based screening for cervical cancer would be throughout in Europe, including the European Union. In many old member states there is either non-population-based activity or partially population-based activity. They have already obtained lots of achievement, so that the current burden of the disease compared to burden decades ago when before screening was started has decreased tremendously, but with better screening we could maybe still halve the current mortality burden in those countries. Then, for instance, in Central and Eastern European hemisphere, there are lots of countries who do not have such effective program historically that could have decreased the burden yet. So that there are big challenges in the European Union how we could be able to implement the Council recommendation better than thus far. So, and the rationale for the work package come from this background, so that it is a necessity to improve the implementation of the current Council recommendation. So it means planning, capacity building, introducing evidence-based implementation in member states if those are not yet there, as well as, for instance, building up infra for the regular monitoring and evaluation systems. And when we think of other fields of early detection, such as health tech, so it is, which can include many other diseases, for instance, the primary prevention, extremely important. So still we think that in other fields of early prevention, there are many examples that when the evidence base is lacking, there are activities for which we are not sure what is good or is it really useful, what is the benefit, what are the adverse effects, what would be the optimal policy with them. And we think that when we combine the experience that have been obtained over the last few decades about the population cancer screening programs, and then think also about the current needs of other fields of early diagnosis, such as criteria for health checks, it could really create some new understanding, and with this exchange we could also come towards development of consensus that would promote also the best practice. So it means that on the other side of the coin, by better implementation of the population-based program, we could same time maybe reduce non-population based activities, not only for those cancer sites that are subject to cancer screening programs, but also on those aspects where evidence is not available about the full usefulness and the balances between potential harms and benefits. So this kind of exchange of experiences could promote better understanding also at the European level. For the other fields of early detection, there are also many benefits that have not necessarily been evaluated carefully. Therefore, we have to be very careful. We cannot go very far in this criteria for other fields in lack of evidence, but at least what we think that it is important in the current situation to start to create foundations for the future policies in the European Union. So the main aims of the package: improving screening program implementation, look on inequalities in cancer screening and how to reduce inequalities, and also give some expert support to regional implementation of the three cancer screening programs currently recommended, and exchange of experience and develop an initial consensus on quality criteria for health checks. For the first objective, this activity period, the first activity period, the partnership and the work package would concentrate on establishing a training course, comprehensive training course that is needed in the management of cancer screening programs. Same time, there are also other activities that are run either in the partnership or other networks related to coordination of evaluation and monitoring of cancer screening, developing planning activity and piloting cancer screening programs in the member states, and also developing accreditation for cancer screening programs in such a way that the new accreditation schemes could take into account all the requirements in the European quality assurance guidelines and recommendations, so that there are broader and bigger projects that are also needed to run same time this training course. But still we think that this training course can provide some important new additions to this overall developmental process in the European Union. This training course will be planned this year, and we would do also one full audit of the real regional screening program this year, and the first pilot course will be organized next year. We plan to include about 15 participants from the regional or national screening management units and centers to the course. And we will plan to pilot that in late 2012. The second objective, identify inequalities in cancer screening, so that there is a literature review that has been contracted that is now under the methodological development and will be performed later on during the activity period. So that would focus on inequalities in participation compliance in screening programs. And then based on this experience also there will be later on a new survey of the national and or regional screening managers about description of the inequalities, analysis of inequalities in the programs in their regions, as well as inquiring on which interventions has been prepared and developed to reduce inequalities. The third objective, expert advice for regions. There will be 3 workshops, one per each cancer type under the screening program, and we hope that these workshops would bring together EU screening expert involved in preparing the recommendations and guidelines, also regional stakeholders and authorities, as well as regional screening managers. And then it would mean also investigation of the current practices as well as current problems, and also show some good examples of good practices and changing practices among the regional stakeholders about the various solutions how to come to the full population-based program. Also, there will be a working group under the Eureka which hopefully would continue other issues, the partnership, but also on this activity later on. For the health checks, I think that we would start with the experience that has emerged in the Netherlands in developing the quality criteria for health checks in that country. First, we will get the report from the Netherlands Standardization Office about their plans. Then also we will start to exchange these ideas and needs and development aspects with other countries and collaborating centers, and then come hopefully up to the end of this project a suggestion of the initial consensus on the quality criteria for health checks. So these are just for this last sub-project some information that have been received from the Go project leader. So that it is now still on the current planning phase, and what is planned is the kick-off meeting in October to plan further the needs, evaluate the needs and plan further activity of how to produce the recommendation. Then there would be project team meetings, and we expect the consensus workshop in June 2012, about 1 year from now. After that there would be the public inquiry also in the member states and publication of the workshop agreement by the European Standardization Office, hopefully at the end of the activity period. So that there is one poster about this sub-project. You can have it there, and if you are interested, so Marlu Pilsma is the co-project leader of this co-project, so she would be happy to get your contact to you. Okay, this was about the scope, so that what we are right now doing for this year, so building up project teams and offices, preparing the final plans. Now we are planning for the schools, finalizing the plan of the audit, and then the audit will be happening for one regional program by October, at October. For inequalities, the schedule is right now on building up the methodologies, the assisting teams, supporting teams, staff, and preparing the final plan, and then start the literature review in such a way that the report would be available already by the end of the first activity year. For the Eureka, it is planning workshops via surveys and via Eureka work group activist. Eureka has been very active in the planning process. There are 3 regions already chosen for the 3 meetings. You will learn that from the website later on. And it is ongoing plan of the first workshop that is scheduled to occur in March 2012. For the consensus criteria, it is now developing the report on the Dutch experience, and then kick-off meeting is planned in October, and hopefully also after the kick-off meeting report plus planning for the survey among other member states could be started. So that these are about the activities, the work package. In addition, we have links with the European Health Science Advocacy Network for Health that is led by the president is nowadays from the Dutch Health Council, and also the Network for the Health Technology Assessment Offices, a European Network Cancer Screening and Prevention Programs, as well as European Code Against Cancer. And this is our collaborating partner list, so that it is variable. Some people are involved in the sub-projects. For some collaborating partners we do not have yet a sophisticated role, so hopefully you would find during the later course of the partnership also nice projects for everybody. And thank you for your attention.